Breast cancer. 2 words no woman ever wants to hear. But surgical advances have made this once deadly disease all the more treatable and survivable. This episode of the Dr. Bob Show covers various types of breast cancers, along with new advances in breast cancer prevention, detection, and treatments. The host, Dr. Bob Overholt, is a board-certified physician in Knoxville, Tennessee. Today's guest is board-certified surgical oncologist, Dr. John Bell.
We're talking with Dr. John Bell, board-certified surgical oncologist, and we're going to be discussing advances in the treatment of breast cancer. John, what does surgical oncologist mean?
It means that I did general surgical training, and then I went on and did a fellowship in oncology training, surgical oncology training.
That's cancer training?
Cancer surgery.
Yes.
And so my training was everything from the esophagus all the way through the GI tract, extremities, and then my life kind of evolved into where I spend most of my time taking care of breast cancer patients.
Tell me about breast cancer. What are some of the facts that people need to know as far as the epidemiology, the frequency, the number of people that die?
Well, breast cancer is the #1 incident cancer for women in this country. Roughly 250,000 cases estimated in 2014. It's the #2 leading cause of death, unfortunately, even with all the progress, and we'll get into that, among women, around 140,000 deaths or so on an annual basis. And that's the bad news. The good news is that through screening and early detection, the death rates have been steadily declining for the past 15 years. So there's real hope.
And that's such a great thing that people know that if they find breast cancer early, you've got a reasonably 98% chance of having a good 5-year survival. Are there different types of breast cancer?
Absolutely. Dr. Bob, when I talk to women about their breast cancer, I try to get them like a tangible explanation. And I tell them to either think of their breast like a lump of grapes or a tree. And so you've got a large stem, it goes to a smaller stem, and a smaller stem, and you get to a grape. Or you've got a big trunk, and it goes to a big branch, smaller, and you get to a leaf. Well, the breast has what we call ducts. Those are like the stems and the branches and the twigs. And we have the lobules, which are the milk-making factory part of the breast, and that's like the leaves or the grapes.
Which one of those is most common?
Ductal, far and away.
The ductal cancer. Can you find that sometimes early? What's the word in situ mean?
In situ cancer means it has not invaded out into the surrounding breast tissues. And even with the word invasive, it doesn't mean it spreads all over your body. It just means that it's moved beyond the site where it began in those ducts.
How's the diagnosis of breast cancer made?
Today, in the era of modern screening mammography, and we've got some great tools now, Dr. Bob, we usually find 80% of them are found through screening mammography, screening imaging.
And what year should somebody start having mammography?
Depends on who you believe. Yeah, I mean, there's controversy, but I believe most sanctioning societies, we believe age 40. Annually, they're beginning at age 40.
So age 40, and I'm a firm believer in that, unless somebody has a family history and you talk it over with your doctor, you may have to do it earlier.
Right.
If you start at 40 and you find a lump in the breast and you suspect breast cancer, how do you verify the diagnosis?
Almost everybody today, Dr. Bob, can have their diagnosis made before they have to go to an operating room. They don't have to go to surgery to have a diagnosis. We generally do what is called an image-guided biopsy. So we'll use an ultrasound, or we'll use a mammogram, or we'll use an MRI, or something to localize it. It's kind of like lining up the crosshairs on a rifle scope, and you find it, and you numb up the skin with a patient awake in an imaging center, and you put a needle of some sort in there and take a piece of tissue out and look at it under the microscope.
So when you get to the microscope and they say, yes, you've got breast cancer, and when they look at that cancer, do they say, boy, it looks like a bad one or a good one, or what do you do at that time? How is it graded, and then what do you do as far as a sentinel node?
Okay, so what we do is, first differentiation is it ductal or lobular? Is it invasive or is it non-invasive?
What does invasive and non-invasive mean?
Again, if it comes out of its site of origin, out of the duct or out of the lobule, it's invasive.
That'd be a bad sign.
It would be a sign that it has moved beyond where it started. It's not necessarily a bad sign.
Good.
Because small invasive cancers that have good other features, which I think we're going to talk about, they do great. Those patients do very, very well. So ductal lobular, invasive, non-invasive, and then we look on the cell surface. And here I talk to people about antennas sticking up out of the cell surface. And there's three really important ones, Dr. Bob. There's estrogen receptors, there's progesterone receptors, and there's a growth protein receptor called a HER2 protein.
Now, those are antennas that pop out of the cancer cell
Itself.
Three different kinds. What do they tell you, John?
They help us make recommendations about what other treatments, in addition to surgery, we might recommend to a patient. And it also helps the medical oncologist decide about chemotherapy versus anti-estrogen pill medication. So it helps us. It also gives us some insight into the aggressiveness of the cancer as well. So there's lots of information that we get from knowing about the receptors, and that's important to help us decide the treatment sequence sometimes, the aggressiveness, the duration. There's lots of factors that go into that equation.
If somebody has an estrogen receptor versus progesterone versus HER2, HER2, which is the worst of those three, most likely, generally?
We think that the presence of the HER2 receptor is indicates a little more aggressive cancer. Yet, we now have targeted medicine that can focus just on that HER2 receptor. The so-called Herceptin is the medication that treats those Herceptin positives, those HER2 positive cells.
So that's a recent advancement that guides you toward how to treatment it. So if somebody has the worst kind, it may not be the worst kind. You've got medicine. How about
personalized medicine?
How about
targeted therapy?
So how about the estrogen receptor sites?
The estrogen receptor sites allow us to treat people with anti-estrogen medications. And there's a couple of different types of those, but it'll either block that receptor, block that antenna, or it'll actually result in a situation where your body will not even produce estrogen, so there's no estrogen to go and stimulate that receptor.
And the progesterone receptor, basically the same thing?
Pretty much the same thing, but no yet medications to target the progesterone receptor. But we know that certain combinations of plus or plus minus tell us more about the aggressiveness or lack thereof of those cancers.
So in the old days, you didn't have that. It was much more difficult to know what kind of treatment to do. Now we can sort of guide it.
Oh, absolutely. In the old days, everybody got chemotherapy, and everybody got chemotherapy against everything. It's like throwing the kitchen sink at it, because we didn't know about some of these receptors, and we didn't have targeted therapies, and so we had a couple of medications, and we gave them to people, and some people responded, and some people didn't.
Now, if somebody has breast cancer on one side, what are the chances of their having it on the other side?
Great question, Dr. Bob. There's so many factors that go into that. Family history, age at the first diagnosis, type of breast cancer, life expectancy. I mean, there's lots of factors. But if you want a general number, it could increase your risk to almost twice of the, quote, asymptomatic general population. So it's real.
These receptor sites that we were talking about, these three antennas, do they sort of help guide you to know what might do, or it may be more genetics?
Well, we haven't gotten into the genetic part of it yet, but if these people do have these receptors and we treat them with these anti-estrogen medications, we can then use those medications to reduce their risk of future breast cancers in remaining breast tissue.
John, you mentioned to me about guided therapy. Tell me what you mean by that.
Dr. Bob, before we go on, let me tell you how grateful I am for you to even have me on this show, and I really appreciate the opportunity to come and share some information with you. So thank you.
You're a great teacher.
Targeted therapy. We now have tests, Dr. Bob, that once we do surgery or do a biopsy and we remove tissue, we can actually send those breast cancer cells for a laboratory test that tests your own breast cancer cells, DNA and RNA, against a panel of other patients who have been through this journey before. And we know how those people were treated, and we know how their results turned out. So we can analyze your specific tumor against those specific panels And we can predict, if we treat you one way, how you might respond versus another way, how you might respond. And what it's really allowed us to do is to avoid giving unnecessary treatment. Back to what I was saying earlier about throwing the kitchen sink at it. Now we know a lot of times we don't need to. We can back off and give very specific therapy that works only against those targets, those HER2 receptors or other things that we didn't have 10 years ago. So we can be very focused to try to minimize the side effects of the treatment.
John, I think that's why it's so important that people understand that the money that they're giving for research is being very productive. Here we've got individualized treatment. Every breast cancer is different. Everyone is treated different. Everyone has the knowledge of knowing what they can do. Now, before we get into the surgery, let's talk about BRCA1, breast cancer 1 and 2 genes.
Breast cancer susceptibility genes 1 and 2, so-called BRCA1, BRCA2. These were identified in the late 90s. Now there's a whole panel of them. There's like 18 different genes that we know now, the so-called Ambry panel and others. And what we know, again, through a simple blood test or a swab of your DNA, an oral swab, we can send that off and we can ask the question, do I have a gene that predisposes me to breast cancer or to ovary cancer?
And that's a key issue too.
Absolutely, because as I like to say, there ain't no mammogram for ovary cancer.
So this is a way we can sort of have a hint or suspicion or knowing that we need to look for that if they've got one of these BRCA1, BRCA2 genes.
That's right. And depending upon which mutation and depending upon your family history, we can put that into a mathematical model. Amazing enough, Dr. Bob, and we can come up and tell people, this is your likelihood of developing breast cancer and or ovary cancer by a specific age, and people can then use that to make decisions about how they want to be treated.
That brings on so many questions. I think that's phenomenal information. I want to get into a couple of things about the surgery. Okay. Tell me, when somebody has a lump and it's cancerous and you get the information and you're going to have to do surgery, the sentinel node, is that still important? Tell me what that is.
A sentinel node is a way that we find 1 or 2 or sometimes 3 or 4. What we're looking for are the lymph nodes that are the first draining lymph nodes out of the breast tissue in the breast region. It doesn't mean they're positive. It doesn't mean they're negative. It just means they're first. And quite frankly, and the very interesting thing about this is that our research shows now that we understand that the lymph node does not necessarily act as a governor. It acts as an indicator for systemic disease. So being able to look at somebody's lymph node under a microscope and say, is it positive or negative, tells us about probabilities that it could have spread beyond the site where it began in the breast. So it's very important to have that microscopic window into the rest of your body, because then that helps us know how aggressively to treat people with systemic agents, be it pills or chemotherapy in your vein.
So if you get a negative sentinel node, that first node that drains from the breast when we've got breast cancer, when it's negative, it's a good indication that it hasn't spread, guides you toward treatment. If you're going to take out a lump, how do you decide whether to do a lumpectomy, a simple mastectomy? What is the difference between all these things?
I tell you, it's really a personal choice. I think if everything else being equal, and I think this is a very important message to our viewers, Dr. Bob, a woman needs to understand that survival is unaltered by which operation we do. So their survival with a lumpectomy and a sentinel node is exactly the same as it is with a mastectomy. It's a personal choice. Now, recurrence rates are a little different, and some studies suggest that recurrence rates for breast conservation, lumpectomy with sentinel node and radiation, are a little bit higher than in mastectomy, but at the end of the day, the survival is no different, and there are ways we can control the disease if they have a recurrence after they've saved their breast.
There's a famous actress that decided to have both breasts removed. That was because of genetic counseling. Why would somebody have both breasts removed, or why wouldn't they have both breasts removed? Again, is that the individualized, and that's where you talk to patients, you give them decisions?
Right. It's a personal thing. My sort of saying for that, Dr. Bob, is pretty simple. The risk reduction surgery that famous actress chose, which is pretty common these days actually, is that is as near zero as humanly possible that we can reduce a person's risk of developing subsequent breast cancer. It's never zero, but that's as close as we can get. It's better than screening, it's better than risk reduction medication, and it's better than anything else we have today. Someday, with research, and as you said, raising money, doing research and learning, when we identify that gene abnormality, we're going to be able to shoot a smart bomb in there and fix that gene and prevent the disease from ever developing.
That was going to be my next question.
Sorry.
No, that's perfect. So you can visualize in the future that we can even prevent it by looking at the DNA, or when they get it, the DNA will tell us exactly what kind of treatment to do, and the treatment is getting better and better. Will there ever be a day where you think that maybe we won't have to have surgery for breast cancer?
I think there'll be a day where we don't have to do the conventional screening that we do today. I think there'll be a day where you can go into the doctor and you can either have a tube of blood or a swab drawn, and they're going to tell you before you can see it on any kind of imaging that you've got the disease or that you're predisposed to the disease. I believe that day will be here, maybe not in my life, but hopefully in my children's life.
John Bell, you give me a very exciting vision of the future for breast cancer. You're a great teacher, a wonderful surgeon, do a great job if surgery is needed, but guiding the patient toward what is best for them. Thank you for coming to the Dr. Bob Show.
Thank you for the opportunity. I'm grateful.
Dr. Bob Overholt is a board-certified allergist practicing medicine in Knoxville, Tennessee. He also hosts a local TV program called The Dr. Bob Show that touches on a wide variety of medical topics, such as the one you've heard today. For more information on Dr. Bob and his involvement in spreading medical education, visit his website at drbobshow.com. Thank you for tuning in. I'm Dasha Telmark. Join us next time to hear Dr. Bob and a guest cover another episode on your health and well-being.